So I like to start out my lectures with a scenery picture or animal picture or something. This is along the chain of lakes where I grew up. I'm from northwestern Montana, Libby. This was where my aunt had a cabin. We spent a lot of time up there doing a variety of outdoor activities. So this is hepatitis and fatty liver disease. The two websites are where Dr. Hughes and I have questions for the USMLE. I'm going to start doing hopefully stuff on Twitter again, but there's a lot of cases on there. And just remember, I have a very strong interest in general and organ pathology. I enjoy teaching the medical students. I enjoy natural disease. And because I'm a forensic pathologist, I have good exposure to natural disease. And I think I have a more broad-based understanding of it instead of a specialized. And so I tend to keep my explanations fairly broad, which I hope are good for the students. Please pause the slide, look at it. Make sure that these disclaimers do not apply to you. If they do, then stop viewing the lecture. Same thing, third disclaimer, read it, make sure it does not apply to you. And then if it does, don't view the lecture. And then the last one is just if you're interested in my teaching style, it's in the introduction presentation. I describe kind of it and stuff like that. So these are my references, all very good books. Start out with one question. So read the question. The idea is that you haven't been exposed to the material yet. You read through it, try and understand it, and then it makes you pay more attention to the lecture, and it's been shown to increase retention. And then we'll discuss it at the end. So talking about hepatitis, obviously one of the main ones is viral hepatitis, A, B, C, D, and E hepatitis forms of viruses. Pathologic changes that we see in more of the acute stage, you'll see more spotty, like out through the parenchyma. And then as it goes into a chronic, which some of them do, B, C, with co-infection with B, D, and in some people E, but not A, you get more of a lymphocytic infiltrate in the portal tract, and that's what we see here. So this is a person with hepatitis C. Then viral hepatitis has risk for cirrhosis. With hepatitis C, it's the highest. Lower with B, and then with D with co-infection, and then very rare in hepatitis E. Doesn't occur in hepatitis A, or essentially doesn't occur. Never say never in medicine. And so with hepatitis, basically what you're getting is you get viral infection of the cells, so the body will kill some of them. And so that you get apoptosis, so you get death of the cell, and no inflammatory response to it other than the macrophages clean it up. So this is an apoptotic cell at the left, what was called a Councilman body. You can see it's shrunken and eosinophilic and necrotic. And then as it's developing, you can see bridging necrosis. The arrow shows that. As a forensic pathologist, I essentially have everything H and E. I don't have all the wide range of stains that surgical pathologists use and everything like that to best show the things. But you can kind of see that disruption there. Autoimmune hepatitis is another form of hepatitis that occurs. It's associated with the DRB1 asterisk allele, more common in females than males, which would go along with most autoimmune disorders. And there's two main types, type 1 and type 2. Type 1 is found in older adults. You can see anti-nuclear, anti-smooth muscle, anti-mitochondrial, anti-soluble liver antigen, liver pancreas antigen. And then kids, you'll see anti-liver kidney microsome 1 and anti-liver cytosol. So unfortunately, I do think antibodies, mutations are good questions because you can give a good clinical history, and then if there's one specific mutation or specific antibodies that are associated with it, you can answer that. So I do think they are worth knowing at least somewhat of with those. You can also get drug-related injury. There's a good listing in Robbins for the ones that are more responsible for cholestasis, necrosis, fat accumulation, fibrosis, cirrhosis, granulomas, and vascular lesions. Various drugs can be associated with each. I'm not going to repeat it. It's in Robbins. And I think the list of drugs that probably can damage the liver is probably very long compared to even what's in Robbins. But the interesting thing is that you can have both predictable and idiosyncratic. So some drugs are known to cause reactions, whereas others, it just happens to occur. Okay, so we'll talk about fatty liver disease. So the morphology of alcoholic and non-alcoholic fatty liver disease is essentially the same. The history and other things would tell them apart. And so what you can see is steatosis. So steatosis is fatty accumulation within the hepatocyte. You can see both macrovesicular and microvesicular. Macrovesicular are large vacuoles. Oftentimes one vacuole fills the cells. Microvesicular are small vacuoles. Sometimes you'll see innumerable small vacuoles, giving the cell kind of a foamy appearance. And then it usually starts in the central vein region and progresses to the portal tract region. You can see steatohepatitis, steatohepatitis in both, where you see ballooning of the hepatocytes. They kind of get enlarged and then have kind of like wispy cytoplasm. You can see Mallory-Dink bodies, or what's called Mallory's hyaline. These are seems like more commonly associated with alcoholic liver disease. And then you can see neutrophil infiltration, what's kind of called alcoholic hepatitis. When I see that, I'll see neutrophilic infiltration in the parenchyma, and I'll see it associated with ballooning degeneration and really prominent Mallory's hyaline. And then fibrosis usually starts as a central vein sclerosis, same place the fat. So remember, fat is kind of a reversible change, but it shows damage. And then once you start getting fibrosis, it's much less reversible. Although, as in Robbins, it's kind of interesting that if you have an alcoholic with cirrhosis and they abstain from alcohol, they can actually start correcting the fibrosis and kind of return more toward normal. So this shows the macrovesicular steatosis and the microvesicular. Top left, you can see most of the hepatocytes have one large vacuole. Bottom right, they have many vacuoles, so it kind of gives it some of a foamy appearance, but you can still see clearly well-defined vacuoles in it. I've always been told that when you see microvesicular steatosis, it's much more concerning. Steatohepatitis, the black arrows show an area of fat, and then it's rimmed by neutrophils. So the neutrophils is the itis, and it's steatosis in the hepatocyte, steatohepatitis. And then Mallory-Dink bodies, a new term for Mallory's hyaline. The top left has it, but the bottom right is the best. You can see at the arrows, it's kind of this ropey, dark eosinophilic condensation of intermediate filaments, and you can see it there quite commonly. Like I said, when I see a case of alcoholic hepatitis, I see it really a lot. So alcoholic hepatitis is where you see inflammation of the neutrophilic infiltration throughout. And like I said, it's associated with ballooning degeneration to the bottom right. So it kind of looks like microvesicular steatosis, but the cells are enlarged and it's kind of more wispy. It's kind of, and so, and I'm hoping that is because it looks like everything that's in the books and everything like that, kind of that enlargement of it. But you can see some of those have prominent Mallory's hyaline and everything like that. And it's not quite like the microvesicular steatosis that we are looking at. Sorry, this is the Mission Mountains. It's between Missoula and Kalispell region, very beautiful mountain range there. So alcoholic liver disease, the mechanism of steatosis, alcohol gets metabolized by alcohol and acetaldehyde dehydrogenase, which generates NADH, and that shunts the metabolic processes toward lipid biosynthesis. So you get more lipid built up, and it's going to accumulate within the hepatocytes. It also impairs the assembly and secretion of lipoproteins, and so lipids will accumulate intracellular. So that's the mechanism by which steatosis occurs. And then mechanism by which hepatitis occurs, acetaldehyde causes lipid peroxidation, and that, as you know, damages the cell. Alcohol itself can damage the mitochondria and the membranes, and then reactive oxygen species generated by the inflammatory process can damage membranes and proteins. So that's kind of the mechanism by which alcoholic liver disease causes the hepatitis and causes the steatosis. And then it can lead to, you can get diffuse fatty liver with alcoholic liver disease, and then you can ultimately get alcoholic cirrhosis. And that's what this is. You can see the nodules of hepatocytes with the macrovesicular steatosis, and then they're divided into variously sized nodules by these fibrous septae. So non-alcoholic fatty liver disease has the same features. You can see steatosis, you can see steatohepatitis, and you can see fibrosis in that. You can see cirrhosis. When I was in residency, we saw some kids who basically, because of obesity and diabetes, had cirrhosis at a relatively young age. Non-alcoholic fatty liver disease is associated with obesity, type 2 diabetes mellitus, and dyslipidemia. And basically the mechanism here is mobilization of free fatty acids from the adipose tissue, and that deposits in the hepatocytes. So with both alcoholic and non-alcoholic fatty liver disease, you can see a diffuse fatty liver, which is at the top left. Bottom right is the steatosis. And then the cup, I hope you can appreciate, those are actually chunks of liver in there, and they're actually floating. Normal liver will sink to the bottom, but this, because the fat will float, and I thought it was a good representation. I couldn't find one from the side. I don't know why I didn't have it, but it is floating in there. So other than non-alcoholic fatty liver disease and alcohol, there are other common causes of diseases associated with cirrhosis. The most common is alcohol, though most alcoholics don't develop cirrhosis. Only about 10% do, but chronic alcoholism is a very common problem, and so there's a lot of people with cirrhosis due to it. The hepatitis C is, if not treated, is very likely to. About 50% of them will develop cirrhosis. But then there are some other conditions as well, too. Hemochromatosis is one. This is due to mutation in the HFE gene, and what happens is basically you get excessive absorption of iron, and then the iron will deposit. And so it can deposit in the liver, causing cirrhosis, in the pancreas, leading to fibrosis and potential diabetes, in the myocardium, causing either a dilated or restrictive cardiomyopathy. And it can deposit in a variety of glands, the skin as well, so the bronze diabetes. It can be a hereditary or acquired. The HFE gene would be associated with hereditary form, but acquired, you can get a secondary hemochromatosis, people who are receiving a lot of blood products and everything like that. The blood will break down, leave iron, the hemosiderin in that. So you can get skin pigmentation, once again, bronze diabetes, diabetes mellitus, can deposit in the testes, so hypogonadism, cardiomyopathy. Like I said, I've seen both dilated and restrictive described. To me, restrictive makes more sense because you have the iron kind of in the skeletal muscle, in the cardiac muscle, so impairing its movement and stuff like that. But I've also seen associated dilated. And then enlarged liver and cirrhosis. So this is hemochromatosis. This is an iron stain. So you can see some blue, but not this much. And so this is all blue throughout. This is why the person's going to develop cirrhosis. And then Wilson's disease is another one associated with cirrhosis. It's the ATP7B gene. And this one affects transfer of copper into the bile and incorporation of copper into ceruloplasmin. So basically, you're going to get accumulation of copper in the liver and decrease ceruloplasmin in the blood because it doesn't associate with it. So they can get a range from steatosis to hepatitis to chronic hepatitis and ultimately to cirrhosis. You can also see injury to the basal ganglia in the brain, and then Kaiser-Fleischer rings are characteristic of it. These are copper deposits in Descemet's membrane. And then alpha-1 antitrypsin deficiency. Most people have a PIMM. Those with PIZZ will have an abnormal level of alpha-1 antitrypsin. With alpha-1 antitrypsin, you can see two things. You can see emphysema and cirrhosis, not necessarily both. You'll see emphysema because the enzyme is needed to help prevent damage to the lung. But in people who it gets built up in the liver and stays in the liver, that can be the ones that are associated with cirrhosis. And so you see what these microscopically the black arrows show, and you can see all around this, you'll see these nice eosinophilic globules, which are usually around the portal tract. So it's kind of interesting. So I've had several cases of this at autopsy. I had one when a medical student was visiting me. We discussed this, and later on they told me in their residency they actually got this right at a known conference. Okay, so with the question, pause, look at it, and we'll go through the answer. Okay, a 33-year-old male presents to an acute care clinic with complaints of not feeling well for the past few days and a yellow discoloration of his skin. So he's jaundiced. In addition, he says that he has some pain on the right side of the abdomen. So right side upper quadrant pain would go along with hepatitis. Physical examination reveals a liver that is palpable below the costal margin, and pressure elicits some discomfort for the patient. He has an elevated total bilirubin, elevated direct bilirubin, elevated alk phos, elevated AST, and elevated ALT. He reveals that after the death of his brother 6 months ago during a car accident, he's been drinking heavily, consuming up to 12 to 16 cans of beer per day, whereas previously he never drank more than 1 to 2 beers per day. A biopsy of his liver performed would reveal which of the following. So of the choices there, because of the alcoholic history, and like I said, in cases where I see alcoholic hepatitis, which there's damage to the liver ongoing, and based on symptomatology, best answer would be the Mallory's hyaline. Obviously, you can see iron deposition if it was hemochromatosis. You could see PAS, positive diastase-resistant globules, which is the alpha-1 antitrypsin. Russell bodies, probably maybe with lymphocytes and stuff like that. Numerous granulomas, sarcoidosis can affect the liver. An undiagnosed infiltrating neoplasm, not likely to cause cirrhosis. And marked lymphocytic infiltrates in portal triads would be potentially hepatitis C, But of the choices, given the history and everything like that, Mallory's Highland, I believe, is the best. So once again, use reflection, think back through the lecture and ask, what are 5 important points? And I hope there are 5 important points from the lecture. Once again, very great technique described in Make It Stick by a medical student who went from the bottom of their class, top of their class using this one technique. So that's why I promote this. That's why there's no summary slide. Okay, and then this is actually not Montana, this is Scotland. One of my good friends from residency ended up in Scotland. I've been over to visit him a couple times. And Scotland is very much like Montana, a lot of water, a lot of trees, but a lot more water there in Scotland. And this is just one of the lochs. So I hope this lecture has been useful. Thank you.